Hello, everybody. This is episode 88 of our podcast, Artificial Intelligence and Cybersurgery. This is the official podcast for our journal, Artificial Intelligence Surgery, the first journal dedicated exclusively to artificial intelligence and surgery. And I will let Dr. Vincent Grasso introduce our next guest.
Yeah, thank you, Andrew. We're at episode 88. It's very exciting. We're moving towards 100. And we have an exciting guest on today. And thank you for coming on Saturday, Dr. Fabio Ausania. And he's a surgeon in Santiago de Compostela in Spain, obviously. And he's got some very interesting things to talk about, his surgical practice, what's happening in Spain, perhaps, how AI is impacting his world. And welcome to the podcast, Fabio.
Thank you very much. Thank you very much. My pleasure.
So, Fabio, are you originally from Italy or Spain?
Indeed. I'll start to resume my story. It's not very short, though. I was born in Italy, in a city very close to Naples. Then I did my medical degree in Rome. And then I decided to move to the UK to perform my registry activity. And I moved to the University of Cambridge at Addenbrooke's Hospital. I did my training there, and last 2 years of my registrar program, I spent them in HPV and transplant. It was a really big transplant unit at the time in Cambridge, the only multivisceral transplant unit of the country also. And then when I finished my program, I decided to stay there for 2 more years as a senior clinical fellow in HPV and transplantation. And then I decided to move to Newcastle upon Tyne, which was one of the other 7 centers where HPV was centralized and the transplant program was centralized. And I spent 3 more years in Newcastle. Very, very good years there. I really learned a lot, and I became a consultant there. And then basically I got married to a Spanish woman. And
all making sense now.
Yeah. And I decided to move to Spain. So at first
But before we leave Spain, yeah. What's your favorite team in the Premier League?
Difficult question, but I have to say Newcastle.
Yeah. Good. That's what I was hoping you would say.
Yeah, I would be easy to say another team, but actually, I really had a very good time with people in Newcastle. So,
great.
Very, very good memories.
And your wife is from where in Spain?
She's from Galicia. She's very close to Santiago de Compostela, where I live now.
Nice.
But actually, we didn't come straight here. We come in a city which is close to Santiago, which is called Vigo. At the time was a massive hospital, was 1,500 beds hospital. And I had the chance to develop the HPV unit, which was already there. But of course, we started at the time with the big laparoscopic program in HPV. And then it was when I moved to Hospital Clinic Barcelona, where I spent my last 9 years, where I was doing HPV and liver and pancreas transplantation. I was actually in charge of the pancreatobiliary unit and the robotic program for advanced HPV surgery, and was really a great experience. From one side, from the HPV side, we managed to develop the biggest robotic program of the country. We published our personal series of over 100 Whipples and robotic Whipples with telemetry, learning curves, and all the complications that you can get during the learning curve. And then I also was in charge with another colleague of the liver transplant program, which is also one of the biggest units in Spain, but also the only unit allowed to perform the living donation from the adult liver donors. And then 4 months ago, I decided to move here where I'm now in Santiago de Compostela, where I'm the director of the Department of Surgery. And it's a new adventure. It's a new responsibility, because in Spain we have divided responsibilities for for areas, not just for hospitals. So in fact, I'm responsible of the general surgery department in 3 different hospitals in 3 different parts of the region. And we are quite a big department because we are 48 surgeons plus 15 registrars, so it's a big program. And we also have the University of Santiago de Compostela, which is the largest medical faculty in Spain. We have 500 students every year, so it's actually the commitment with teaching. So in a short summary, this is the way how from Italy I travel around. I did some fellowships along these years, so I spent some of my time abroad as well. One of the
What are you talking about? You only spent time abroad.
Yeah, well, I don't know where I'm from, so
Yeah.
basically, I just say abroad, outside Europe. Let's put it this way. I spent 6 months in University of Illinois at Chicago. At the time, there was Professor Giulianotti just arrived. It was 2001, so the Twin Towers here. And I was there with Professor Benedetti, and I do remember at the time I thought it was incredible to see in 2001 living donation from kidney transplant.
Well, University of Illinois, no? Or was it University of Chicago?
Illinois at Chicago. Yes.
Okay. Yeah.
Yeah. So.
And he's been there since 2001?
I was there in 2001 for 6 months.
But Giulianotti has been there since that long?
Yes, he actually performed. I think he performed well. I think I'm not saying something wrong because this is part of it. I think he performed his first robotic Whipple in 2000. And then I remember Professor Benedetti telling me that he presented robotic Whipple at the Congress of the American College of Surgeons in 2000, I think. And he couldn't believe that. So he decided that if you really can do that in Italy, come here and do that here.
Yeah.
So this is how the adventure started, I think, for him. But he just arrived at the time. There was already a robotic program at University of Illinois, and I remember Enrico Benedetti doing kidney transplant by robot. That was, to me, was so ahead. So it was really, really, really great experience. Yeah.
Oh, that's great. That's great. And now we're in a new age, right? We're in the AI age. So one of the nice things about being an HPB surgeon is there's a lot of need for help in the operating room. Very complex surgeries. It's not like you're doing an appendix or a right colon. You're doing, very complex anatomy. What excites you the most about like AI now, or what upsets you the most, or like what are you worried about, or kind of just what are your global thoughts on AI? As you know, it's on the tip of everybody's tongue right now.
Yeah, absolutely. I think for surgeons, the big dream is to have an instrument that helps you during the surgery, and like sort of GPS that tells you you should go there, you shouldn't go there. Especially if you perform surgery like Whipples or major hepatectomy, because retroperitoneal surgery and liver surgery, these are like 3D surgeries. It's not like gastric or bowel surgery. So you really need some guides. Sometimes you really don't know where the arteries or the small veins can be. And we're all afraid of making a mistake. This is the problem with this surgery. A mistake means that you have a bleeding. A bleeding means that the patient can die. If you have an urgent conversion during a robotic Whipple, the patient, he can die. He can die because by the time you get a good laparotomy and your hands in, it might take some time. Yeah. So the big dream is to get some useful help. What excites me most is the same thing that upset me most. Means that I think I would have expected 25 years ago that now we would already have had an instrument that helps you during the robotic surgery to guide you, to show you where the anatomical structures are. But we don't have this instrument yet. It's not mature. I've seen some models there. I'm participating myself in developing a model of guided surgery during the operation, but still, I think we are quite away from having an instrument like that real and feasible and manageable by surgeons. So
you have a lot of students that you have to teach. You know, when I give lectures to students, they ask me like, what field in medicine is going to exist and what field is not. And, that's becoming harder and harder to answer. So what, and I also pose this to Vincent, like, what do you guys tell them now? I mean, I know I tell them do what you love, just like what my mentors told me, like, you do what you love and then it doesn't matter, if you're passionate about something. But I'm not so sure I can be as cavalier as previous generations. I think some specialties might not exist in the numbers that they do today. Do you have them like do masters in AI? Do you encourage them to do PhDs? How are you dealing with this change?
yeah, no, absolutely. I think answering your questions, what do we say to students? I mean, I always tell them just keep asking me this question every year because our answer will probably change every year. So I think these are difficult times where we still think that most of our job is not really replaceable by AI because the human component, because of the ethical problems that are still there, because the technology probably is not already there yet. So at this moment, I mean, we haven't seen anybody fired because of the AI in Spain, at least. But it's going to be very difficult to answer this question next year and in 2 years and in 3 years. I'm pretty sure that AI is a great instrument. We shouldn't stop using it. We should encourage people using them. And this is why I tell medical students, of course, I mean, we have to teach them about AI, and because I also teach to biomedical engineering students, so we have a specific topic which is AI in surgery. But I think you're right. I think people should do whatever they feel they passion to, because otherwise, there's no point in doing something that you don't like.
Yeah, definitely.
Yeah. So
What,
passion.
yeah. What do you think, Vincent? I mean, you're in New York. You know that CEO of that healthcare system who said as soon as he can replace radiologists with AI, he wants to do it. What do you think? What fields are in danger? Are no fields in danger? What do you think?
It's interesting. If you're a medical student and you want to become a surgeon. So if you're a fourth year medical student in the US, Fabio, you have to do 5, 6, or 7 years of surgery before you can practice if you want to do a specialty or not. 7 years between 2026 and 2033 is like a billion years, that the innovation and things that are changing is so fast that you can't do anything because you're stuck in that window of training. So you may finish surgery and then the things that you learned are completely outdated. And now what do you do? So I think part of the challenge is technology is moving so fast in surgery. And secondly, Andrew, unless you're really well trained, how could you ever get a job in a department of surgery where there's people that are there 20 years? How do you get a job? You have to wait for somebody to retire. Something has to happen. So you may find yourself kind of stuck thinking that you'd work in New York City in a big hospital and there's no room and things changed. So unless you're willing to go live in the rural areas of the United States where there's a lack of surgeons, you may not be able to work as a surgeon. I frankly think that general surgeons, I did general surgery and subspecialty after, but I always thought a general surgeon and a family practice doctor bolted together in one person would be really busy. You could do endoscopies, you could do minor surgery, you can do primary care, you'd be busy all day long. I don't think general surgeons want to do that, but
maybe they have to.
territory, right? They keep losing territory.
Yes.
So if you're a general surgeon and you did 2 years of internal medicine and a year of family practice, you'd be the busiest doctor in the United States. You'd be busy all day long. I think things will move that direction for general surgery.
Interesting.
Because, things are changing and technology lets us do different things. But in Italy and Europe, I think if you're a surgeon, it's very hard to get a job in a department, right? I mean, maybe it's harder in Spain than the US to get a job. A young guy, young surgeon, young person. The bureaucracy is different, right, Fabio?
Yeah, every system is different. And I'll tell you something which I'm not sure we can share outside Europe, at least outside of Europe. No, basically what I'm saying is that, as you know, we have basically the way our registrars choose the specialty is a national ranking. So you have a national exam, and then based on your ranking, you can decide where you want to go and what type of specialty you want to choose. So the first 100 places are almost all for dermatology. So being a surgeon is not in the dreams of medical students, because there has been a change of culture, and I'm talking about south of Europe, where basically people want to have less stress. And there is a big difference between being a dermatologist and being a surgeon. And they want to have fixed time. So they want to know what time they have to go to work, and they want to know exactly what time they can leave the hospital. So I'm not saying that it's going to be easier to find a job as a surgeon, but certainly I don't think it's now the dream of most of the medical students, because the culture of young people has changed as well, and we have to adapt ourselves.
They're a lot smarter than we were. Let's be honest.
Of course.
So you mentioned that no, you don't see doctors losing jobs right now because of AI, but in the United States, bariatric surgeons are losing jobs. So is that affecting you in Spain at all? Have you noticed anything in the UK? Have you heard from your friends? How is that playing out?
No, basically, I think medical treatment have entered now the treatment of obese patients, but they have not replaced them. They're being introduced in the system like neoadjuvant treatments, let's put it this way. Yeah. So, and because we have a 30% rate of obesity in the population, which is one of the highest in Europe, wow. I think it's going to be a long way. Yeah, we have hundreds of patients in the waiting list for bariatric surgery. So, I think this is actually a good thing for the system to have medical treatment and to avoid all this pressure on waiting lists for obese patients. So, yeah, I think it's a positive issue, actually.
So, one of the things I advocate for is that each department, radiation oncology, they have a physicist, a full-time physicist on staff. So I feel, or I wonder if surgery departments should have like an AI specialist on staff, or a statistician, or what have you, or at least an AI officer, or what do they call the United States? Chief Medical Information Officer, Vincent?
Yeah, Chief Medical Information Officer.
So in your hospital, now that you're part of the leadership, what support do you have for this? Do you have access to a computer scientist? Do you have access? How does it work in Spain?
So basically, the experience I have now is the same I had when I was in Barcelona, where the hospital decided to build a new department called innovation, just innovation. And then in this department, so the head of the department was actually an anesthetist that went to MIT and stayed there for 3 years and then came back. And all the members of this department were actually not fixed to this department. There was one for each department, one for surgery, one for gynae, one for cardiology, one for neurology. And every 15 days, there was a meeting of these people of this department to decide what type of strategy could use the hospital to grow up and to develop new instruments in the field of AE. They went from having a system that could record images in theater, having a system that could record the outpatient clinic consultations and prepare, of course, all the documents. And then also some people that had more interested could also learn how to prompt, which is, of course, a step above. But you need some time for that. But anyway, I think overall the hospital, all the hospitals have the wish to develop AE in their own hospital, because I think there's a benefit in terms of productivity as well. So I can see that, and in my department, I have a person that is in charge of the innovation. It's not one for subspecialty because it's impossible to have a job to contract so many people. But I have one person that I decided to leave in charge to develop innovation and to prepare meetings, to spread news amongst the colleagues. So yes, definitely. I mean, we want to develop that, but also, I mean, there is part of our institution has a large interest in technology development. We have patents. We try to develop through public calls projects that are finalized. Most of them, as I said to you, to image analysis, but also to developing new tools in robotic arms. So we're working on that. We are really interested on that.
So, Vincent, back on what I was talking about, that CEO, you're saying replacing radiologists. One of the easiest things to replace with AI is actually a lot of the decisions that businessmen make, right? That's much easier to automate than being in the operating room, what have you. How do you see that playing out, right? If they want radiologists to be replaced, and we obviously want bureaucrats to be replaced with AI, how do you think that's going to play out, Vincent?
Well, I mean, number one, the leadership, the C-suite, the bureaucrats control cash flow. They control expenditures. They execute the business plan. They're the hardest things to remove in an organization, is people that control spending and everything, right? They control basically everything. So that they're really hard. It's hard to replace that function. We all know that basic accounting can be done by AI, right? It's very straightforward to do basic accounting, not complex financials. But even that stuff has gotten better and better in AI. So everybody's job is at risk in some point, right? There's some percentage of all of our workflow that can be replaced. I think that the challenges and what I've seen, that the difficulties are, physicians, although they have these associations like the American College of Surgeons and all these things, they generally don't work well together. They don't band together and create the counterbalance to, quote, the business people that are running things. And physicians are not trained to work together within a business organization. They're trained to be independent thinkers because they take risk. That's very different from the bureaucrats. So I think this is another challenge. If you're training surgical residents and in 5 years they don't take one business course, they don't take one medical billing course, they don't take anything in the business of medicine, then they get thrown to the wolves with the business people that are running things. So I think the only chance we have to get parity is getting physicians like you and I have done, and others, Fabio, get an MBA, get a master's in something outside clinical practice, and then you have a seat at the table, right? You can start pushing back. Otherwise, I think they just steamroll everyone. It's really hard.
Yeah, that made me realize something. You guys know about these AI hospitals, right? And we're always focused on the clinical, like, oh, how do they do AI hospital? But it just occurred to me, if you had a hospital run by AI instead of paying all of these, the C-suite, you obviously need a C-suite, but
Sure.
reduce that number by a factor of, whatever that factor is, and all that money you would save. An AI hospital just run with AI would save so much money that it would kick all the other hospitals behind. That alone would be such an innovation. And I wonder when they talk about AI hospital, are they also factoring that in? Is that part of the AI hospital? I don't know the answer, but I think it would be very interesting to find that out. So, Fabio, I know you have a recovering child or a recovered child, so congrats. I'm very happy for that.
Thank you.
If you have any last comments, and then I'll let Vincent close us out today, and we'll all start enjoying what's left of our weekend.
No, I just want to thank you very much for this opportunity to have this nice talk to you, and thank you for your mission of spreading the importance of eye in surgery. I mean, you've been the pioneer of this, and I can see this growing up every year, becoming bigger and bigger. And I just want to advertise again the second meeting you are promoting now, which will be shortly.
Thank you.
I'll try to be there. I think it's a very good initiative. So hopefully we'll all be there.
Oh, we would love you. I wish I wish I knew. We would have. You got to let me know. I'll add you onto the program.
Thank you very much. Thank you for that. And
Okay.
thank you very much to Vincent as well.
Thank you, Fabio. Thank you.
Thank you.
All right, guys. Have
Take care.
a good day. Bye bye.
Take care.
Bye-bye.
Thanks again.